Hello. For any of you watching who don't know me, my name is Dr. Lowell Chambers. I'm a general surgeon with an emphasis in this practice on trauma, surgical critical care, and hepatobiliary pancreatic surgery. In regards to the ventilator support of our surgical and trauma patients, I've become increasingly convinced that our current standard management with low tidal volume principles as endorsed by ARDS is an inadequate standard, and that a better way forward for the care of our patients is an alternative vent mode, airway pressure release ventilation, APRV, and specifically the time-controlled adaptive ventilation approach to APRV, or TCAV. We're going to break our discussion down into three basic parts. During this first session, I'm going to share why TCAV, why I've developed pretty strong feelings that TCAV is a better ventilator option for most of our patients. During the second session, we're going to discuss the how of TCAV. How do you effectively ventilate a patient and safely ventilate a patient with TCAV APRV? And during the third session, we'll go over some case studies and discussion of avoidance of some pitfalls with TCAV APRV. Well, let's start by looking back at the data which established the low tidal volume standard. Standard that's guided most of our ventilator practices over the last 2 decades, the May 2000 ARDS trial published in the New England Journal of Medicine. This study was a randomized prospective multi-center trial across 10 centers between 1996 and 1999 involving 861 ARDS patients who were ventilated with either ACVC with 12 milliliters per kilogram of tidal volume as the control group versus 6 milliliters per kilogram tidal volume in the study group, and with a plateau pressure kept less than or equal to 30 in the study group versus a higher plateau pressure allowance of 50 in the control group. The study was actually stopped early as a result of an interim analysis showing a statistically significant mortality benefit in the study group, the lower tidal volume group, at 31% mortality versus approximately 40% in the group receiving quote unquote traditional tidal volumes on average 12 milliliters per kilogram. Additionally, other parameters were favored in the lower tidal volume group as well in relation to shorter time to extubation and number of ventilator-free days. And so the conclusion of the ARDS trial was that the lower tidal volume protocol should be utilized with patients for what were then called acute lung injury and ARDS. Unfortunately, embracing the ARDS low tidal volume ventilation strategy has not led to widespread significant improvement in outcomes. Since the American European Consensus Conference initially established standard definitions of ARDS in the 1990s, the mortality has remained constant between 30 and 50%. So this begs the question, is there a better way forward for at least a subset of ARDS patients? As we attempt to answer this, I think it's potentially helpful to look back with a more critical eye to the 2000 ARDS trial, which established the low tidal volume ACVC as the standard of care. Because again, as these authors emphasized in the 2014 Current Opinions in Critical Care Summation article, it seems that the incidence and overall mortality of ARDS has not changed substantially since the original ARDS study. The current mortality of adult ARDS is still greater than 40%. So is the ARDS trial the end-all, be-all? And perhaps should we look at this study maybe through a more critical lens? Several investigators from Bethesda did this several years ago, a number of years ago, actually within just several years of the New England Journal ARDS trial coming out. And utilizing the Freedom of Information Act, they obtained the primary data from the ARDS-NET trial. And in looking at that, there's some interesting observations that certainly I was unaware of, as I've, for the last 20 years, essentially taught our residents ARDS-NET as gospel for how to best manage at least the vast majority of ARDS patients, and also for really guidelines to ventilating all patients, as the lower tidal volume strategies really took hold as a general vent guideline, at least in most units, for ventilation, not just of ARDS, but kind of all patients, thinking that if it's good for treatment of ARDS, it's probably good for prevention too, which certainly is, I think, a reasonable thought process. Has been the thought process that I've had for the last few years, although I've had more of an emphasis, I believe, on following plateau pressure and then more recently driving pressure, but nonetheless, essentially following the guidelines of ARDS-NET. Looking back at the study, though, it turns out there were actually 6,000 patients screened. Of this, just shy of 3,500, 3,448 patients were actually eligible for the study. Of these, only 861 patients, about a quarter, were enrolled. The remaining 2,587 patients were eligible but were not enrolled for various reasons. And those reasons, again, the group from Bethesda were able to tease out from the primary data, which they had been given the right to see, and these are listed here. What I think is most important from this slide is not the reason that a number of these patients were excluded, although I think that to some degree begs some questioning when you have a study where 3/4 of the patients are not enrolled that are eligible. But in any case, what's I think more important and perhaps a little bit disturbing is that those patients were followed out who were eligible but were not ultimately part of the trial. And they had an average tidal volume utilization of 10 milliliters per kilogram. So significantly higher than the low tidal volume standard. And interestingly, look at their mortality. Almost identical to the low tidal volume group. So you've got this study population group of 861 patients, and then you've got this much larger group of almost 2,600 patients, and the ones being ventilated with the 6 milliliters per kilogram, the others being ventilated with the 10 milliliters per kilogram, and there's no significant difference. Furthermore, as they teased out the data, it turns out that while a subset of patients certainly did receive benefit from the low tidal volume ventilation, as has been preached, those patients specifically that had a higher pulmonary compliance actually did worse with lower tidal volume ventilation as compared to the standard, if you will, which averaged out actually at 10 milliliters per kilogram. And so not only do you have in the classic ARDS-NET study 3/4 of the eligible patients not being included in the study, but when you look at the outcomes of all of the patients who are eligible, there was really not a demonstrable difference between 10 milliliters per kilogram and 6 milliliters per kilogram. And furthermore, the 6 milliliters per kilogram tidal volume, or the low tidal volume ventilation, in patients that had more compliant lungs had a higher mortality. So the group of investigators from Bethesda summed up when they published this in Critical Care Medicine in 2005, I think appropriately so, that in light of the marked relationship between compliance and mortality in the low tidal volume arm of the ARDS-NET trial, a single ventilatory strategy, such as 6 milliliters per kilogram low tidal volume ventilation, may not be ideal for all patients with ARDS, and then the term was in vogue, acute lung injury. In other words, one size may not actually fit all. Now, for those of us that have been preaching and teaching and utilizing the low tidal volume as a standard, this is kind of a bitter pill to swallow, but it really stands to reason that as complex a pathologic process as ARDS is, it probably is not amenable to a single intervention, at least a single non-adaptable, if you will, or non-adjustable or minimally adjustable strategy. And I think we've kind of lost our way a little bit, not just in regards to this, but certainly in regards to a lot of things in relation to SARS-CoV-2 management. But we've lost our way a bit as scientists. And I think we need to recall the admonishment of one of the most brilliant of our founding fathers, Benjamin Franklin, who reminds us that if everyone's thinking alike, then no one is thinking. And I would propose that it's time we all stop thinking alike in our dogmatic acceptance of low tidal volume ventilation as the end-all be-all of ventilator management in ARDS. Dr. Atul Gawande, in his book Better, defines 3 basic requirements for improvement and success: diligence, doing right, and ingenuity. And I believe that the history of critical care is highlighted by men and women who exemplified this. Women and men who were unwilling to accept inadequate standards and who, with diligence and ingenuity, overcame challenges and advanced the field. Whether it was Florence Nightingale recognizing the need for the more critically injured to receive more focused care during the Crimean War, or the neurosurgeon Walter Dandy recognizing the critical need to avoid delays in the management of neurosurgical patients and therefore establishing not only a dedicated unit for neurosurgery, but response teams, a brain team as he called it, which is essentially a forerunner of our modern response teams. And he was establishing that way back in the 20s at Johns Hopkins. Or Bjorn Ibsen, who had the courage to challenge the dogma of the times, dramatically advancing the care of bulbar polio patients with the application of mechanical ventilation. Or Peter Safar, who codified ACLS and pre-hospital EMS protocols, as well as working with Dr. Bill Shoemaker and Dr. Max Weil to pioneer modern critical care in this country. Each of these giants, upon whose shoulders we stand, had a stubborn unwillingness to accept inadequate status quo, to an unwillingness to accept an inadequate standard. In regards to ventilator management, I believe that there are 2 current physicians who are demonstrating a similar mindset, and I've become increasingly convinced that these physician researchers have an important message for us. The first of these men is Dr. John Downs. Dr. Downs is an anesthesiologist. He's also an inventor and innovator in anesthesia and respiratory medicine, and is the primary inventor of both IMV and APRV modes of ventilation. It's interesting, the development of APRV actually goes back to when he was a fellow in the time of fellowship in the University of Florida back in the 1970s. And he was there confronted with, one night while he was on call in the ICU, with actually a University of Florida professor who had sustained severe pulmonary injuries from blunt trauma. The patient had severe hypoxic respiratory failure as well as hemodynamic instability. And as they struggled to stabilize this very critically ill patient, Dr. Downs, working along with a cardiothoracic resident at the time, or cardiothoracic fellow, I believe at the time, floated the first pulmonary artery catheter, the first Swan-Ganz catheter, which had been placed at the University of Florida, and utilizing that to help guide the hemodynamic assessment of the patient as they were struggling to oxygenate him. They increased the PEEP from 8 to 10 and then to 12. And with this, the oxygenation improved. But they were very carefully watching the patient's hemodynamic status, because at that time it was felt that reaching a PEEP of 12 was all that most patients would tolerate from a hemodynamic standpoint. But as they increased the PEEP, they noticed not only did the oxygenation improve, but also so did the patient's hemodynamics. As the patient was still critical, Dr. Downs, who at this point looked like this as a young man, increased the PEEP on to 14, and then to 16, and then to 18. And with each step, he and the cardiothoracic fellow observed improvements not just in oxygenation, but also in the patient's cardiac output and hemodynamic status. Although pleased with the patient stabilization, Dr. Downs did have some fear and trepidation that he describes regarding how rounds with his faculty were going to go the next morning, seeing as how they had been taught not to go above a PEEP of 12, and the patient was still sitting at 18 as morning came. His anxiety was likely increased as the next day was an academic day, and they had a visiting Grand Rounds professor that the University of Florida was hosting that day, Dr. Heinrich Bendixen. Dr. Bendixen, just by an amazing coincidence, was an internationally recognized leader in anesthesia and pulmonology. He was actually the author of the leading respiratory textbook of the era, the same one which had established the 12 PEEP max guideline. And so in addition to presenting his unconventional approach to a potentially skeptical group of his faculty, the young Dr. Downs also had to face arguably the leading authority in the world at the time on the subject. After his presentation to the patient, there was reportedly an uncomfortable interval of silence, after which Dr. Bendixen praised the young physician for his care of the patient and encouraged him to study this application of high PEEP CPAP in patients with severe lung injury. And so he did so. He went on to study this while still at the University of Florida with 12 patients that he applied PEEP again up to 18, with documenting not just improvements in oxygenation, but also hemodynamic tolerance and to some degree improvement. This was published in the March 1973 edition of Anesthesia and Analgesia. Dr. Downs went on to continue to investigate and clinically use high PEEP CPAP in his management of patients, first at Wilford Hall in the United States Air Force during his time there, then back for an interval at the University of Florida, and then for a time in private practice, actually, in Illinois. Then in 1985, he was named the Director of Anesthesia Research at The Ohio State University. Amongst other accomplishments there, he went on to perform seminal research on tailored vent modes of IMV and high PEEP CPAP, along with Dr. Christine Stock. A sticking point for them, though, in applying the high PEEP CPAP to critically ill patients was inadequate CO2 exhalation. You could help the patients hemodynamically, you could certainly help their oxygenation, but applying it to a vent mode which allowed for significant management of hypercapnia was a dilemma. And as Dr. Downs relates looking back, he reflects, as is often the case with sudden enlightenment, a question occurred to me one night. If I can provide CPAP and ventilate patients with a positive pressure breath on top of CPAP, why not simply decrease the CPAP briefly, say for 1 second, and allow the patient to exhale carbon dioxide. Essentially, CPAP with releases, which is fundamentally what airway pressure release ventilation is, CPAP with releases. And so Dr. Downs and Dr. Stock modified or created a modified CPAP circuit that had an exhalation valve, tested it initially on each other reportedly, and then performed animal studies supporting the safety and the utility of airway pressure release ventilation. They patented the ventilator model in 1986 and then subsequently published on it the following year. The initial studies in animal models supported utilization from a safety standpoint and from an oxygenation standpoint and from a hemodynamic standpoint, the potential utility of APRV, and was supported in an editorial where they initially defined the concept by none other than Dr. Bill Shoemaker, who, again, along with Max Weil and Peter Safars, really credited as kind of the founders of modern critical care in the country. So APRV was initially described by Dr. Downs and Dr. Stock in 1987, and in their paper they referred to as a new way to administer simultaneously a supportive level of CPAP, and specifically high PEEP CPAP, and also assist with CO2 elimination. Simplistically put, CPAP with releases. Subsequent to the good results in the animal trials, they performed a trial in coronary artery bypass patients, which was published in Chest in 1988. And this study essentially confirmed the animal studies demonstrating stable cardiac output and hemodynamic status in these patients, along with improvement in oxygenation and an overall actual decrease in airway pressure, such that they concluded that the APRV ventilated lungs of both apneic and breathing patients with acute lung injury supported oxygenation without impeding cardiac performance. So it was a good way to oxygenate the patient, and it did not have significant cardiac side effects. And then, with the appropriate humility, given the limited amounts of the study, I recommend that further study be required to determine whether this mode of ventilation is useful in the population of patients for whom it's designed, those with severe acute lung injury. But it never really caught on. Despite this promising start, despite kind of an endorsement by Dr. Shoemaker, while APV hung around as a non-conventional vent mode and kind of a salvage method utilized by limited groups of practitioners for rescue from severe ARDS, APRV failed to receive widespread acceptance over the ensuing 2 decades. The reasons for this were, I think, well defined and looked at from a historical perspective in this article, The 30-Year Evolution of APRV, published in Intensive Care Medicine Experimental a couple years ago, back in 2016, I believe it was. And the major point that they made was the primary reason for APRV likely not being more mainstream in its acceptance was somewhat of a lack of consistency in the way that it was used. And APRV meant a lot of different things, with different clinicians and investigators utilizing wide ranges of pressures and timings. And you can just see from these schematic waveforms here significant differences in what's functionally being done with the ventilation in each of these, obviously, but all of these were referred to in the literature as APRV. And so you really had multiple strategies with which the APRV technology was being utilized, leading to, not surprisingly, mixed outcomes. And also, as utilization of APRV evolved to some degree there became a recognition that a personalization or an adaptive component, if you will, to the APRV may be necessary for it to work as compared to a fixed APRV strategy. So studies with APRV over the years have meant a lot of different things, and lumping these heterogeneous approaches together, not surprisingly, led to inconsistent findings as you look over the literature. Nonetheless, by the 2005, 2006, 2007 time frame, increasing evidence supported benefit for airway pressure release ventilation in ARDS management, and this began to emerge more convincingly. In a review published in the journal Trauma in 2007, there were 16 studies cited involving 398 patients, 14 of which demonstrated benefit without significant adverse sequelae or side effects, whereas 2 demonstrated equivalence. And so the authors of this paper came to the conclusion that APRV demonstrated significant promise in ARDS management, and it was then, at that point, recognized as at least a great, or not great, but it's a good salvage option or rescue option with difficult oxygenation cases. Around the same time frame, the highly regarded University of Tennessee trauma program became interested in the mode after they successfully salvaged a severely ill patient for whom they were unable to adequately ventilate via other modes. This prompted a small study in which they tracked the responses of 46 severely injured ventilated trauma patients as they were transitioned from low tidal volume AC strategy to APRV. And they observed fairly rapid and sustained improvements in oxygenation, as well as overall hemodynamic stability. This led to a prospective trial, which was ultimately published in 2010, with 63 trauma patients who had been on the ventilator for greater than 72 hours, being randomized to low tidal volume ARDS-net ventilator support versus APRV. You can see that within the APRV group, the Apache score is a little higher, consistent with a higher level of acute illness. You can see that the number of ARDS, or then again the term was in vogue of acute lung injury, patients were higher, 45% versus 34%. So arguably, by happenstance with the randomization, the APRV arm were a little bit more severely ill, at least in regards to Apache 2 scoring and in regards to oxygenation. The outcomes showed no statistically significant difference between the two groups. However, as the APRV subset had higher injury severity scores and a greater number of ARDS patients, the mode was again felt to show significant promise and likely to be of benefit in at least a subset of ARDS patients. Within the study too, I found helpful protocol that prior to kind of the establishment of the TCAV method, which we're going to explain in depth later on, and certainly in the next discussion that we have and talk about how to effectively use APRV. But there was a pretty nice early protocol, which is similar in some regards to TCAV, that I utilized as I was beginning to start to try to incorporate APRV within a subset of my critical care patients' care. Looking at this, we see a couple of important aspects if we enlarge this, and we'll talk about this much more fully in the next lecture. But We see an adaptive T-low based upon expiratory flows, and this likely was why you saw some benefit as compared to more fixed APRV modes. There's also a personalization of the T-high setting, which is good, but I'll provide data later to argue the range here doesn't go quite far enough, which is probably why more benefit wasn't seen in this trial. So, but the Tennessee study, I think, was a noteworthy early application, if you will, of a modern iteration of APRV. More recently, a single center randomized prospective trial was published out of West China. A little bit larger study, 138 ARDS patients. Inclusion criteria required a p-def ratio of less than 250. And these patients were randomized within 48 hours of intubation after a variable interval of ventilation, but not over 48 hours on ACVC, essentially ARDS-net, low tidal volume, assist control, volume control strategy. Once they were randomized, then they were randomized to continue on low tidal volume ventilation via the ARDS-net protocol, or into an APRV group with a somewhat similar approach to that of TCAV, which we'll shortly describe in detail, but with some differences. In the Chinese study here, the P-high was set at what had previously been the plateau pressure on assist control, but they maxed it out at 30, so you couldn't go higher than 30, which I think there's some limitation to, again, as we'll talk about when we talk about the how of doing TCAV. They also had an adaptable T-low, which was adjusted to terminate at greater than 50% of the peak expiratory flow rate. And we'll see that adjustability is a good thing, although the guidelines for it is a little bit different than TCAV does. The T-high was indirectly set in this protocol by setting a release frequency of 10 to 14 times per minute. And the P-low was set to 5, whereas with TCAV, we'll talk about the P-low being set even lower, 0, or depending upon the ventilator, 1 to 2. They set the P-low to 5. So as we describe TCAV, we'll see some potentially important differences here in regards specifically to T-high and to P-low. But in regards to the outcome, comparing this form, if you will, of APRV to low tidal volume ventilation, we see that the groups were split with 71 in the APRV group, 67 in the low tidal volume group. The duration of mechanical ventilation was essentially a day for the APRV group, and a few hours less than that in the low tidal volume ARDS-net group. There was a greater incidence of chronic comorbidities, most notably COPD, with the ARDS-net group. So the ARDS-net group were arguably at least slightly more ill from a chronic basis, whereas the Apache 2 score was higher slightly in the APRV group, so arguably, potentially, the APRV group at least slightly more acutely ill. Low number of trauma patients, right around 10% of trauma and surgical patients in this study, so primarily a medical study here. And looking at the outcome variables with this form of APRV and compared to low tidal volume ventilation and this Western China single center study, the study group, or the APRV group, did show a statistically significant improvement in time to extubation and number of ventilator-free days, with trends to improvement being noted in regards to mortality, length of stay, and need for tracheostomy placement. So overall, at least mildly strong support for APRV, demonstrating shorter time to extubation, to successful extubation, as well as trends toward decrease in mortality, length of stay, and whether or not the patient only needed a surgical airway. Also of note, Dr. Zhao and his colleagues demonstrated a statistically significant difference in analgesia administration and paralytic utilization. There was a much lower number of sedatives used in the APRV group and almost a complete lack of need for ongoing neuromuscular intervention, neuromuscular blockade in the APRV group. This was such a striking difference that the authors actually expressed concern with this as a potentially confounder in regards to the demonstrated benefit in regards to extubation time, and they performed a multivariate analysis demonstrating that the benefit in regards to time to extubation persisted after correction for the difference in the sedatives and paralytics utilized. But I would suggest that this observation itself, that of not having to sedate the patient as much, not having to paralyze patients with neuromuscular blockers, is in and of itself a significant benefit. I mean, if we can give our patients less sedation and less neuromuscular relaxants, less neuromuscular blockers, I think we all recognize that as potentially being of huge benefit in and of itself. And the Zhao study is just one of many experiences documenting that properly set APRV is a pretty comfortable vent mode compared to most of the alternatives. And essentially, patients do not require neuromuscular blockade, and they have a significant decrease in need for sedatives. Another example is this study, which was published back in 2001, where paralytic use, you'll note, after transition from either pressure control ventilation or an AC type of ventilation, paralytics dropped from 74% to essentially zero, from 74% to 4%. The sedative use dropped from 100% of patients down to 68% of patients, so about a third of patients were able to be completely taken off of sedation. And so very significant impact here on the need for sedation and paralytics that is seen with APRV. And these are just two of a number of studies which have demonstrated that. So there's reasonable support in the literature for utilization of APRV, particularly in the setting of ARDS, with a number of potential advantages as summarized here. Why then has it not been more widely embraced? I think the primary thing, which I'll just kind of sum it up in a little bit different words than Dr. Frawley and Dr. Habashi did here, but it's just different. I mean, it is significantly different. How the ventilator is set, how it's managed, how weaning is performed, it's different, and that makes us uncomfortable. And there's also some nuances to using it, which require some effort and time. And with our busy schedules, it's frankly just easier to stick with the status quo. But then we're stuck with this inadequate standard of care, or this inadequate status quo in which 3 to 5 out of every 10 patients with ARDS is dying. Are we really satisfied with that? Well, I hope, and the medical ICU director at Baltimore Shock Trauma, the second gentleman, along with Dr. Downs, that I want to talk about, is a pulmonologist named Dr. Nadar Habashi. And Dr. Habashi has refused to accept this inadequate standard. Since the early 2000s, he's utilized APRV as the primary vent mode for essentially all patients as shock trauma. During the time, refining its utilization and achieving some pretty impressive results. Now, long before I'd heard of Dr. Habashi's work, I knew of the work done at Baltimore Shock Trauma, and it started with Dr. R. Adams Cowley. Dr. Cowley was an influential Army and civilian trauma surgeon. He's also a thoracic surgeon, actually a very innovative and cutting-edge thoracic surgeon in kind of the golden era of cardiothoracic surgery, evolving as a separate subset of surgery. Amongst his multiple other accomplishments, Dr. Cowley was the first to describe the golden hour of trauma. He was the originator of trauma center designations, statewide EMS organizations, civilian helicopter medevacs. And he was just a giant in both trauma and thoracic surgery. And he was essentially the founder of Baltimore Shock Trauma. Dr. Cowley's impressive work has been carried on by the current director, Dr. Tom Scalia. And while I've not had the privilege of working with Dr. Scalia, my time in the military afforded me the opportunity to closely work with several colleagues who trained under him and had worked with him. And I've also had the opportunity to hear him speak on a number of occasions. And I can tell you that Dr. Scalia has a passion for the advancement of trauma care that is unparalleled. His integrity and dedication are without question. So I was hearing this guy, Habashi, lecture, and I was initially pretty skeptical because, I don't know what this APRV thing is. And, as far as I'm concerned, ARDS is gospel, and, I'm thinking there's not much here for me. But then I hear him say that, he's working at Baltimore Shock Trauma with Tom Scalia, and just knowing the passion and the integrity that Dr. Scalia approaches practice of trauma care with, that made me take a closer look. And as I looked at, the data that Dr. Habashi was presenting and the literature that he generated and was generating, I became increasingly impressed with the approach. And over the last 2 decades, Dr. Habashi and his team have evolved an airway pressure release ventilation approach, a specific one that they've coined time-controlled adaptive ventilation, or TCAV. The characteristics that make TCAV, if you will, or a specific subtype or subutilization of APRV, is a long inspiratory time where the T high is typically greater than 90% of the cycle, at least after initial stabilization on the APRV, with low and very quick releases. And they actually set on the Draeger vents that they use at shock trauma, they set the P low to 0. That doesn't seem to work on the vents we have, so I've typically been setting it to 1 to 2. We can talk about the pros and cons of that. There's certainly some argument perhaps for utilizing a P low of 5, such as was done in the Chinese study, but we'll talk about that all when we get to the how of APRV. But short releases with very low pressures and a long inspiratory time is the TCAV method, if you will, of APRV. And they emphasize that it utilizes time rather than pressure, parameters to favorably influence pulmonary mechanics. The initial introduction of APRV at Baltimore Shock Trauma was favorable, being associated with a decrease in ARDS mortality down to 21%, which even at that point was favorable compared to the 31% in ARDSNet. Now, obviously, could be apples to oranges because you've got different patient populations, but anyway, it should raise interest. And as they saw these initial good results, APRV essentially became standard of care at shock trauma, and the majority of patients are ventilated or started to be ventilated with APRV. Since then, and as they kind of evolved the method, if you will, to that of the currently described TCAV methodology, the ARDS mortality has dropped down into the teens and even single digits now. And probably most impressively, and the thing which has convinced me as much, probably more so than anything else, is a significant decrease in the occurrence of ARDS, which they're seeing, such that APRV, at least with the TCAV methodology, may not only help decrease ARDS mortality, but also prevent its development in the first place. So data from shock trauma argues that TCAV APRV can not only improve outcomes in ARDS, but also potentially help prevent it from developing in the first place. And that's why Dr. Habashi advocates for TCAV APRV use in almost all ventilated patients. His perspective is it's like wearing a seatbelt. You use it every time you get in the car to try to avoid injury. Every patient who goes on a vent should, in his view, be on APRV to decrease the risk of lung injury. Before we get to some outcome data, let's look at the basis for TCAV. Conceptually, why could TCAV APRV offer advantages? The first is that TCAV APRV allows for spontaneous breathing, even with high levels of vent support, even with ridiculously reversed IDE ratios, the patients can still be spontaneously breathing. And maintenance of spontaneous breathing is beneficial for a number of reasons, the most important of which is that spontaneous breaths are more evenly distributed and favor the larger, better perfused lower lungs, whereas positive pressure ventilation without spontaneous breathing disproportionately ventilates the smaller, less perfused anterior and upper airways, leading to potentially significant ventilator perfusion mismatching. And Dr. Habashi illustrates this here in a lecture which he gave a number of years ago now using dynamic cross-sectional imaging.
Between paralyzed ventilation and the huge diaphragm moved way up into the chest, collapsed lung. We have a lot of movement in the sternum. You can see the chest wall, anterior chest wall, moving quite a bit. In CPAP breathing, it's the abdomen that's moving. The chest wall is actually pretty silent. And you can see that there's more movement down here, just much more favorable, even distribution of ventilation, which ultimately I believe is the way to protect the lung.
So think about it. Why does pronation help with oxygenation? By favoring the lower, posterior, larger capacity, better vascularized lungs. That's exactly what spontaneous ventilation does. And so TCAV accomplishes this without the significant downsides of proning. And in the third podcast, I'll show several experiences documenting near complete or significant decrease to the point of essentially not having to prone anyone with severe ARDS, because you're able to accomplish the same thing without proning the patient when the patient continues to spontaneously breathe and is being supported with APRV, and at the same time being able to have significant reversal, for example, of IDE ratio and other significant support. So it's better to pull air in than to push it in, as you get more even distribution, and again, as you get better utilization of those larger, better vascularized lower airways. Now, this is not a new observation. Data dating back to the 1970s supports this. The challenge is, again, is how you address this in a severely hypoxic patient who needs an altered IDE ratio with conventional positive pressure ventilation, because that's very uncomfortable and typically requires deep sedation, if not full-on neuromuscular relaxation. APRV is not associated with this discomfort, so the excuse me, patients don't require levels of sedation which suppress spontaneous breathing, and as a result of that, you're able to minimize DQ mismatching by continuing the preferential, at least relative to non-spontaneous breathing, ventilation of the lower lung fields. So other than perhaps during the transition from assist control or PRVC to APRV, or maybe certainly after initial intubation, you really don't want to, and it doesn't make sense to deeply sedate or paralyze patients on APRV, because that takes away one of the major benefits, that of spontaneous breathing. I remember we had a pulmonologist years ago, pretty fresh out of training, and he would use APRV. Somebody would always neuromuscular relax patients on it, which really does not make sense, because one of the big reasons that APRV seems to work is it allows you to spontaneously breathe, and therefore you have these benefits which we've just cited, and which I think Dr. Habashi demonstrated eloquently, of spontaneous breathing. This also is specifically illustrated here in this porcine lung model, where these pig lungs, which underwent a acute lung injury with oleic acid, and then they compared what the lungs looked like paralyzed versus spontaneously breathing, both on APRV. So these are both APRV ventilated porcine models. Up here you have neuromuscularly relaxed, and you can see a significant lower lung field collapse and atelectasis and airspace disease here, versus that of the spontaneously breathing pig, where you see much clearer lung fields and therefore much better oxygenation, and ultimately, as we'll talk about, less ventilator-induced lung injury. So spontaneous breathing is good. Additionally good is the fact that, as we've already alluded to, due to the relative comfort of APRV, it permits less paralysis and less sedation. And obviously that's a good thing for a myriad of reasons, right? I don't have to tell those of you that care for patients in the ICU. I mean, avoidance of decubitus ulcers, helps minimize the deconditioning that we otherwise see, helps keep delirium down. All of the other downsides which come from prolonged sedation and immobility can, to at least some degree, be mitigated by the fact that patients on APRV are not near as uncomfortable as patients on most other, perhaps any other vent modes other than perhaps CPAP. TCAV APRV also works by minimizing ventilator-induced lung injury. Gary Neiman, a researcher out of Syracuse, and Dr. Habashi have published extensively on this. They recently published a review on the subject in Annals of Intensive Care, which, if you're going to go to one paper to kind of sum up most of their bench research, at least on this, and the model research with animal models, etc., this is probably the one paper to read, as it's a very nice summation of years of their research. Mr. Neiman presented much of this data at the AARC in 2020, and I've utilized several of his slides here. The crux of this matter is correcting a misconception that alveoli are injured in ARDS primarily due to over-distension. In actuality, it appears that the primary culprits of ventilator-induced lung injury are instead repetitive alveolar opening and closing and shear stress on the airways with stress multipliers, not the degree of distension in and of itself. This was demonstrated in a porcine model in which two groups of pigs were subjected to acute lung injury and were both then ventilated with a high plateau pressure of 40. So higher than typical plateau pressure. We know typically want to keep the plateau pressure at 30 or under. So plateau pressure 40 in both groups. And then one group was subjected to high dynamic strain with lots of repetitive alveolar opening and closing, etc., while the other received only low strain. Despite the high plateau pressure, in the low strain group, the lungs remained relatively normal. Here you see high plateau pressure, but low dynamic strain, pretty much normal appearing lungs at the time of necropsy, and histology confirmed that. Whereas in the same plateau pressure group, but with high dynamic strain, there was significant injury, which was apparent both grossly and histologically at the time of subsequent necropsy. And as Mr. Neiman and Dr. Habashi pretty eloquently describe in a number of their mechanism and model papers regarding APRV and ARDS, the lungs behave as a viscoelastic system, such that they can tolerate higher pressures without injury, provided that particularly rapid shearing forces are avoided. And with TCAV, the lungs are kind of, as Mr. Neiman likes to say it, nudged open and held there with relative little alveolar wall movement, rather than being repetitively blown open and then allowed to collapse again, as you see with low tidal volume, standard ARDS-NET low tidal volume ventilation. And Mr. Neiman illustrates this with a rat lung model.
So what we have here is a rat lung with that has ARDS. The ARDS class part is pink, or is dark red, and the pink is the healthy tissue. We're going to hold this at inspiration for 1 second, and which is a typical conventional breath inspiratory peak. And as you can see, there's no change in the red to the pink. Here we're going to have the TCAV breath. We're going to hold it for approximately 5 seconds, which is a typical CPAP phase or T high. And you'll see at the exact same inspiratory pressure how many alveoli we're going to get recruiting. So here, as you can see, we're at 3, 4, 5, and you can continually see the red going to pink over these 5 seconds. So the exact same pressure in the CMV and the TCAV breath. The only difference is the inspiratory time is held a lot longer. So this is, and again, due to this viscoelasticity, this is what is causing the lung to progressively open or to be nudged open over time.
In addition to being associated with less movement and therefore less shear stress on the wall of the alveoli, this also facilitates better oxygenation through sustained recruitment. I mean, if you just think about it, comparing AC with TCAV, the recruitment zone, is vastly higher with TCAV. And this leads to better oxygenation through sustained recruitment. Again, with TCAV, time is being used to open the lung and stabilize it. And Mr. Neiman uses the analogy of it's like an orthopod setting a fracture to get it back into the functional position, and then holding the fracture there with a splint or a cast to minimize further movement and injury. Essentially, that's what TCAV does with the lung. The minimization of alveolar wall movement and alveolar collapse is again demonstrated here, this time with in vivo microscopy.
The biological evidence for this. Here we have a long expiratory time, and you can see alveoli are collapsing and expanding with each breath. All we did here is shorten the expiratory duration, and we stabilized these subpleural alveoli. So again, showing that the only thing that alveolar collapse is very sensitive to the amount of time they're exposed to the lower pressure. And again,
so just to go back for a minute, as we play this up here, you'll see all this movement, whereas down here with a very short release time, you have much less movement, therefore much less villi, which is occurring. Consistent with this, TCAV animal models demonstrated favorable compliance, driving pressures, and tidal volumes relative to conventional low tidal volume ventilation in a number of these models. Observations which are also supported by gross and histologic findings in the animal models at necropsy. As you can see here, higher tidal volume, but overall driving pressure is significantly less. Lungs will look a lot healthier than over here. Now, in relation to the driving pressure, it's important to make a clarification, and I don't want to get too granular here on TCAV settings, as that's the focus of the next lecture. But there's a frequent misconception that if your P high is, let's say, 25 and your P low is 0, then the driving pressure in that patient is 25 minus 0 or 25, and that is not correct. It's not correct because with TCAV, the T low, the time in the release, is so very brief, typically around half a second, that there's not time for the pressure to actually drop all the way to the set P low of 0 or 1 or 2 or whatever it is. You're very quickly, once you're at about 75% of the peak expiratory flow rate, your release is being truncated and you're going back to your P high, a higher pressure. And so you can, at least on a Draeger, calculate what that driving pressure is, because on the Draeger, at least, I've tried this on our vents, and maybe I just haven't done it right, but I haven't been able to do it yet. But you essentially hit the expiratory hold on the Draeger, as Maria Madden, one of the senior respiratory therapists at Shock Trauma, is demonstrating in this slide that I took from one of her podcasts. You hit the expiratory hold, and that's going to hold at the end pressure right as the release ends. And you'll see here the setting on the vent here is a P high of 38, P low of 30, but it's not 38 minus 0, it's 38 minus essentially 28, because with a very short T low, that's the lowest pressure it has a chance to get to. So driving pressure with TCAV is not P high minus P low, it's P high minus your end expiratory pressure, which is typically probably somewhere around 40 to 60% of the P high. So in looking at driving pressure with APRV as compared to with volume control or pressure control, you can see overall lower driving pressures and a slight benefit in mortality in this early study done by the Shock Trauma group. So driving pressure is favorable with TCAV as long as you understand the appropriate way to measure it. Another benefit of the TCAV approach is its adaptability. And this is, again, in relation to ventilator-induced lung injury. You know, the need for the vent mode to be adaptable. And TCAV has that. Its adaptability is important. And that's likely the primary reason why TCAV works better than other applications of APRV, as well as better than low tidal volume ARDS-NAT approach. You know, with ARDS-NAT, one's applying a weight-based tidal volume. But there's a big difference. Let's take your stereotypical 70 kilogram patient. You know, so you're going to give them 6 milliliters per kilogram, that's 420 milliliters. But there's a big difference if you've got very severe ARDS, as pictured on the left here, moderate or mild, in regards to how much functional lung volume is being ventilated by that 420 milliliter tidal volume breath. And so you can have very small volume of functional lung and severe ARDS, in which case, you know, injury will result if you have higher tidal volumes. But you can also have a more sizable volume of functional lung, in which case the ventilation may be inadequate. And that's likely why the higher pulmonary compliance patients, actually in the ARDS-NET study, when looked at more fully by the Bethesda group, why the more compliant lungs actually had a poorer outcome with lower tidal volume. They were probably becoming atelectatic and being relatively underventilated in that arm. And so again, it's not one size fits all. There needs to be some adaptability to it. So how does TCAV adapt to changing lung compliance? It's done with adjustments to the T-low setting. And we'll talk about this extensively in the next presentation, so I don't want to get into it an enormous amount here. But data generated by Dr. Abashi and others support that for restrictive lung conditions, such as ARDS, the T-low should be adjusted to truncate the release time as the expiratory flow rate drops to 70%, around 75% of peak. And in models, they demonstrated that this was associated with the best aeration and the less ventilator-induced lung injury. So you get optimal alveolar inflation and minimization of wall stress by keeping the T low at truncation at 75% of peak expiratory flow rate. And this is for ARDS and restrictive lung pathologies. Here's kind of a generic schema, if you will, of expiratory flow patterns, and I still have certainly a lot to learn in looking at flow patterns, and our pulmonology colleagues, I think, are much better versed at this. This is something I've neglected in the past to my detriment, and I'm trying to kind of play catch up and learn now. But just, if you let the lung just exhale completely, the expiratory flow pattern is going to kind of look like this. Whereas if you terminate that at 50% of peak expiratory flow, it looks more like this, takes on a less locked off shape and more of a rectangular shape. And then if you cut it down still further, you get this more stretched out look here, skinnier rectangle, if you will. And this is kind of what you want to see, or this is what you want to see with restrictive processes such as ARDS. If you're ventilating somebody with an obstructive process such as COPD, this is a little bit more what you want to see, and we'll talk about that again more in the next discussion. Improved hemodynamics. So reasons that we'll touch upon during mostly the final presentation. APRV facilitates left heart emptying and increased cardiac index, increased cardiac output. And this was demonstrated in 2001 by Kaplan and his colleagues, who soon after transitioned from a volume-controlled or pressure-controlled standard type of ventilator strategy in their patients, noted a significant improvement in cardiac index, a decrease in lactate levels, increase in urine output, and a 50% reduction in vasopressor need. And so in most patients, hemodynamics are significantly improved with APRV over most other vent modes. And there's numerous papers that have documented over the years improved hemodynamics with APRV in the cardiac literature, in the neurosurgical literature, in the OB literature, in the thoracic surgery literature, and it just goes on and on. For the most part, patients do better hemodynamically on APRV than other vent modes. Now, there are some exceptions to this, and there are important exceptions to know about. Right heart failure patients, due to pulmonary hypertension and other etiologies of right heart failure, do not do well with APRV. APRV definitely increases the afterload faced by the right heart. So patients with known right heart failure, patients with pulmonary hypertension, tend not, those are a couple of the settings where APRV is probably not the right vent mode to use. Patients which are hypovolemic also tend to, with APRV, get decreased venous return and become hypotensive. So if your patient is not adequately resuscitated from a volume standpoint, they won't do well with transitioning to APRV or being put on APRV. And this is so much of an issue that they actually have a protocol at shock trauma with leg raises and other modalities to document whether the patient has an adequate volume status or not prior to APRV being initiated. So you want to make sure your patient's adequately volume resuscitated. And I think as surgeons, we're pretty in tune to that, but it's particularly important if you're going to put a patient on APRV dependent. It's also important to recognize that patients that are placed on APRV, TCAV or otherwise, if their lungs are maybe a little bit more compliant than you anticipated or than is typical for patients being put on this, at least as a rescue mode, again, I'm going to advocate for utilizing it in all patients, and this might be a little more common of a thing to have to look out for in those instances if the lungs aren't as stiff. But the other pitfall which can happen is hyperinflation. And this happens or occurs in patients who respond more rapidly than typical to institution of APRV. If the patient's lungs, again, are more compliant than anticipated, they can become hyperinflated, particularly if the T low is on the shorter side and the P high is on the higher side. Evidence of this is kind of a squaring off, if you will. Here's the nice waveform that you want to see with that T low set to about 70-75% of peak expiratory flow rate being truncated at that point, and you have this kind of stretched out rectangle. A nice drop here in the pressure, but not all the way down to zero. So this is what you want to see. When you start to see this more squared off waveform, that's concerning for a number of things. It could be just that your lungs aren't as stiff as they were before, but it could also be that you're kind of fighting to exhale and then meeting resistance to it. And you'll look at the patient clinically, and you can see that they're uncomfortable and they're almost trying to force an exhale if they're unsedated, which if they're on APRV, they probably should be. So if you start to see these squared off waveforms, if the patient's starting to become tachypnic and tachycardic and getting lower volumes, and particularly if they're starting to become hypotensive, one thing you need to think about, well, you need to think about tension pneumo. That's one thing, tension pneumothorax. But in the absence of tension pneumothorax, this may be due to hyperinflation. You get a stat x-ray, and what you'll see is something like this, where the patient's diaphragms compared to before have become flattened, and where their cardiac silhouette has become more narrowed. So flattened diaphragms, narrowed cardiac silhouette, and lung fields which have cleared more rapidly. This is not pneumo, this is a pacing pad here, but lung fields which have cleared more rapidly than you would expect to see typically. So patient with worsening hemodynamics, with squared off waveforms, with evidence of forced exhalation, potentially the development of hypotension, chest x-ray which shows flattened diaphragm, narrowed cardiac silhouette, atypically cleared lung fields, think of hyperinflation. And what you need to do in those instances, you need to pretty quickly, much quicker than you typically do it, decrease that P high, get the P high down, and in some instances also increase the T low. Now, if the patient's still severely hypoxic, as you drop that P high, you may pay a price on the oxygenation side to the point that you may have to stretch out the T high some. That isn't typical, though, because you don't typically get hyperinflation of lungs which are that stiff. And so it's a bit unusual that you'd have to fight that. For the most part, if you see evidence of hyperinflation, drop that P high, and you're usually going to be able to get away with it in that patient, but you do have to recognize that they'll go on and code on you. Now, this is one reason amongst many why when you're transitioning a patient to APRV or to any vent mode for that matter, that's not something that we as physicians should just do over the phone or do and walk away. We really need to be at the bedside for an interval of time to see how these patients, to see, along with respiratory therapy and along with nursing, to as a team kind of see firsthand in real time how the patient is responding. Now, a final reason why TCAV APRV makes sense from a conceptual standpoint is that it allows for minimization of diaphragmatic disuse atrophy. An interesting study was conducted by investigators at the Pennsylvania Muscle Institute in Philadelphia, subsequently published in the New England Journal of Medicine, in which they carefully examined muscle biopsies from the diaphragm of 14 brain dead patients who had been mechanically ventilated without any spontaneous breathing, so with pure positive pressure ventilation for a range of 18 to 68, 69 hours. So essentially from a half day up to 3 days, these patients were on a ventilator with pure positive pressure ventilation and no spontaneous breathing. And so they took muscle biopsies of those at the time of the organ donation or the organ harvesting. And then they also took muscle biopsies from the diaphragm of patients having thoracic surgical procedures who had been breathing normal up to, an hour or so prior to that. So essentially prior to anesthesia induction, they had been spontaneously breathing like normal. And they compared the histology of the non-spontaneously breathing patients to those who had been spontaneously breathing. And there was, just within that time frame, significant muscular atrophy noted, as you can see here, with both fast twitch and slow twitch fibers. Here's the control patients. These were the ones that had been breathing normally up until the time of induction, so they had only been on positive pressure ventilation for an hour or so as they were undergoing their thoracic surgery, whereas these patients had been on non-spontaneous breathing, positive pressure ventilation for up to 3 days, and you can see the significant difference in the muscle from a histologic standpoint. And this amount which was lost translated on average to about a 55%, so almost a half decline in function. So diaphragm disuse is a significant issue, and the diaphragm is not the only respiratory muscles. Similar studies have demonstrated the other respiratory muscles are affected as well. And so it's a positive observation that, again, it really just goes back to that spontaneous breathing. You have another favorable standpoint of APRV is, your diaphragm muscle stays strong. Now, while it's a positive observation that diaphragm muscle function is preserved with spontaneous breathing, such as that made possible with APRV, the natural concern is the same one which has limited the effectiveness of SIMV as a vent mode, and that is too much energy expenditure to the work of breathing, which the metabolically challenged, critically ill patient may not be able to afford. However, with APRV, it appears this is not as much of an issue as it is, for example, with SIMV. And this work, published by Herring et al. And Chesta in 2005, APRV was noted to facilitate ventilation such that less energy was expended relative to even uninjured lung. You can see here the amount of blood flow being required to the respiratory and skeletal muscles, and you can see that it's actually lowest with spontaneously breathing patients on APRV, even after having received lung injury. And so with APRV, your diaphragm's still working, it's still staying conditioned, it's still staying strong, but it's not generating all this huge energy sink by significantly increasing the work of breathing. So looking at all of this information from a hypothetical standpoint, then APRV makes sense as event mode. And this has been supported by numerous lab models, some of which are summarized here, again in Mr. Niemann's presentation. And the mode has also been validated by a number of clinical experiences, some of which are listed here. Now, a frequent criticism is that the majority of these studies are retrospective or small single-center prospective studies. And APRV as a mode lacks the support of a large multi-center randomized prospective trial like the ARDS study. And certainly there's validity to that. And Dr. Abashi recognizes that, and he brings that up a number of times in his talks. But the dilemma that I think that he has is that he has a process that he's been using for 2 decades now, and he's seen that it works effectively and that it's, quite frankly, better than anything else for these patients and for this problem. So how do you ethically randomize patients under your care to a protocol that you know that you're convinced is inferior? Quite frankly, I'm not sure that a randomized trial in which 3 out of 4 of eligible patients weren't enrolled, but are followed, and without the intervention, do as well as the study group. And then this isn't reported by the authors? Is that really the highest standard of science? In any case, having said that, let's look at the paper which at least personally convinced me that changing to TCAV APRV, at least in ARDS trauma patients, is the most validated approach for at least that subset of patients. I'm not saying everybody, although I think I'm kind of coming to that. But this study is specifically looking at trauma patients, and so let's just keep it focused on trauma patients. This is a retrospective comparison of a previously prospectively obtained group of patients at Baltimore Shock Trauma that were then compared with a meta-analysis of all U.S. trauma ARDS experiences that have been reported with over 100 patients. And of note, these are all trauma patients, which is quite unlike ARDS-NAT, which only, by my recollection, 4% of patients in the 2000 ARDS-NAT study were trauma-related ARDS, and all of those came from a single center in Seattle. So this is a study dedicated to looking at ARDS in the setting of trauma. And Dr. Abashi and colleagues laid out their rationale in this study to extending TCAV not only to ARDS patients, but to all ventilated trauma patients. And they can say it more eloquently than I can, so I'm just going to read here that patients are generally transitioned to protective ventilation after ARDS is developed. This late transition may exacerbate lung injury and perpetuate ARDS development. In fact, the majority of patients develop ARDS within 48 hours of admission, suggesting that early intervention from the get-go, essentially, with a preemptive ventilator strategy before ARDS is developed, may prevent the progression of lung injury. Preemptive mechanical ventilation strategies applied before ARDS is established could transform the clinical paradigm from treating ARDS to preventing ARDS from occurring. And so in this study, the Baltimore Shock cohort, 231 polytrauma patients, which were cared for between 02 and 05, ages range between 16 and 65. To meet the inclusion criteria of the previous study, and hence this prospectively obtained database then looked at retrospectively for this study, injury severity score of 17, so at least moderately severe trauma patients by definition, and at least 1 femur fracture. They contrasted this with the meta-analysis from the literature, which included 66,199 patients in 16 studies, with these patients being cared for and reported between 1995 and 2012. and they had to report out the percentage of ARDS in trauma patients, and there had to be more than 100 patients involved in the study. Here's basically the data, and they're broken down by center and by publication. And in looking at the results here, the patients treated with TCAV and shock trauma were in the upper quartile of injury severity with a mean ISS of 30. That's severe injury. Once you get an injury severity score above 25, I mean, that's a legitimately injured patient that's at risk for, or a significant risk for morbidity and mortality. But despite that, the mortality at Baltimore shock trauma was in the lowest quartile at 3.6%. So highest quartile of ISS scores, lowest quartile of mortality, 3.6%. So sicker patients, and they did a lot better. Now, the pulmonary aspects are not all that kills patients after trauma, obviously. Primary things that kill patients from trauma are bleeding and head trauma. So the lower mortality may have as much or more to do with the other aspects of care delivery at Baltimore shock trauma. Nonetheless, that low mortality is certainly noteworthy. From an ARDS standpoint, from a ventilator standpoint, though, what I found more convincing was the exceptionally low incidence of ARDS in these patients at 1.3%. Only 1.3% of this cohort of, 231 severely injured patients developed ARDS, and zero mortality from pulmonary dysfunction was seen. So nobody died specifically from the ARDS, and few people, despite having a very high risk, developed ARDS. And so you compare these outcomes, you can just look at each of the studies and compare the shock trauma data, and there's a striking degree of better outcomes in the TCAV shock trauma group. Looking here specifically at the ARDS percentage and the mortality, again, striking differences between the other experiences. And these were legitimately severely injured patients, again, and looking at this mean ISS score 29, I mean, really approaching 30. I mean, these are severely injured patients, elevated lactate, and a significant number, particularly of elevated AIS scores. And just for example, the ISS scores, for those of you who don't know, the ISS scores are factored from the 3 highest AIS scores in a logarithmic fashion, which has been found to have a direct correlation with mortality. But the ISS scores are from the individual AIS scores, and 79%, so essentially 89% of patients in the shock trauma group had a chest AIS score of 3 or greater. What does that mean? That means patients with 4 more rib fractures, or at least several rib fractures with the presence of a hemothorax, hemopneumothorax, or pneumothorax. So again, patients that have taken pretty good blows to the lungs, which we know places them at risk for pulmonary contusions, which is an independent risk factor for the development of ARDS in trauma patients. But yet they had this exceedingly low rate of ARDS occurring. Additionally, all of these patients had a femoral shaft fracture. That was part of the initial study. And some of them had more than one long bone fracture. And this, puts them at risk for fat embolism syndrome. And the manifestation of fat embolism syndrome, along with the systemic inflammatory response syndrome, is an acute lung injury, or ARDS. Additionally, the TCAV group got a lot of fluid and a lot of blood products, mean of pushing 8 units of packed cells, 9 units of FFP, 11 liters of crystalloid. So on average, 8 units of packed cells, 9 units of FFP, 11 liters of IV fluid. These are certainly predictive numbers of a high risk of these patients having ARDS, trolley or otherwise, qualitatively. But we don't have to rely on qualitative recognition. There's a quantitative prediction score, the lung injury prediction score, or LIP score, which was validated in a multi-center effort published in 2001 in the American Journal of Respiratory Critical Care Medicine. And with this, a number of predisposing conditions and acute risks are assigned point values. These point values are added up to give you your LIP score, which then correlates with the risk of the patient developing ARDS. In applying the LIP score to the shock trauma data, the mean LIP score was 8.7, which translates to an expected incidence of ARDS of 38%. 38% predicted, 1.3% observed. And so Dr. Abashi and colleagues concluded, I think very legitimately, that their results suggest that early application of APRV in high-risk trauma patients can significantly reduce ARDS incidence and mortality, and that this represents a potential breakthrough from treatment of an established syndrome of ARDS to prevention of ARDS before it develops. And so, yes, we want to do better at treating ARDS, but I think it's an even more noteworthy accomplishment if we can prevent it before it starts. And it seems that the TCAV APRV approach holds significant promise in regards to this. So why? That's our answer for this module. Why TCAV APRV? Because it makes sense conceptually, and also because there's now significant emerging data that it improves outcomes with ARDS, and perhaps more importantly, or maybe more significantly, it also appears to decrease the incidence of ARDS and from it developing in the first place. The Shock Trauma Group has established a non-proprietary website. They initially called it aprvnetwork.org, but now they've now changed to tcavnetwork.org. So tcavnetwork.org has been established by Dr. Abashi and his colleagues in order to assist providers with transitioning to utilizing APRV safely and with as little pain as possible. Thank you for your interest and attention. It's been my privilege to present this data. Obviously, it's not my data. This is the work of others. I'm simply trying to put it into practice and stand on the shoulders of what I would regard as some modern day giants of critical care medicine, at least in the trauma setting. And this is some of the noteworthy members of Dr. Abashi's team pictured here. And having answered now, hopefully, why TCAV APRV, I think, should be embraced, we will next move on in our next module to how it's implemented and used. Thank you.